Good afternoon, Ms. Kofke here. Going to talk to you today about sensory perception. So basically we're going to talk about why our senses are so important and different things that can happen if they are not working appropriately. So first off, you have sensory reception. So that's the process of receiving data through your senses. And then you have sensory perception. So perception is the conscious process of selecting, organizing, and interpreting the data into meaning. So it's influenced by the intensity, size, change, or representation of a stimuli, as well as your past experiences, knowledge, and attitudes. So for a person to receive the necessary data to experience the world around us, four different conditions have to be met. The first thing is a stimulus. You have to have something, some agent or action that influences and initiates a response. So in this case, it is hot donuts. And everything about the hot donuts. So the second thing after the stimulus is that the receptor or sensory organ must receive the stimulus and convert it to a nerve impulse. After the nerve impulse has been conducted, after that, the impulse is conducted to the brain. The brain has to receive and change that impulse into a sensation. So we're gonna compare this with donuts now. So visually, you see the hot donut sign. You auditorily hear somebody scream next to you how excited they are about it. Your olfactory senses then kick in and smell the deliciousness. Next thing, you can feel the warm donut in your hand. And lastly, you can taste the donut as it melts in your mouth. If any of these processes are interrupted along the way, the sensory message won't be received, and then you don't get the full sensory experience of the donut. So let's talk about some things that affect our sensation. One thing is going to be developmental. Just like everything else we talk about, things are going to differ developmentally. So there is a basic need for sensory perception and sensory, and for you to be stimulated. For growth, for babies, they need to be soothed and rocked and held. Singing, they like to see changes in lights and colors. What you'll see is babies that are going to be risk for having an alteration is going to be, say, babies in a NICU that where they try to stimulate the womb, but and so that's going to be necessary for sensory development as they grow older. And then as far as developmental goes too, at the other end of the spectrum, you see a decrease in sensory function in older adults, but we'll talk more about that in a little bit. Culture is going to differ. So what's normal in one culture is maybe not acceptable for somebody else. A good example of that is touch. For some people, touch is very soothing, and it is something that they need to stay calm. And in other cultures, that may not be the case. It may be inappropriate for you to touch. Another thing that's going to impact our sensory and perception is going to be personality and lifestyle. So everybody's kind of different and has been around different things. So they're going to experience and be able to handle stimulation differently. If I live in a cabin in the middle of the woods, it's going to be sensory overload for me to then go into a large city to visit. That's going to be a lot coming at me. And then that's going to be the same for occupations. For example, musicians or somebody that's around loud music may have damage to their hearing. My father-in-law was an airline pilot, and he that being in the cockpit is so loud, it's a regular thing for pilots to have hearing loss, so at an earlier age. Stress and illness can impact the amount of stimuli that you're able to take in. You can easily get overloaded whenever you're under a lot of stress. So think about yourself right now. You have a lot on your mind from nursing school and you feel overwhelmed. And if your spouse then comes home with a list of 500 things that you need to do, maybe you can't process all those 500 things, and you may need a timeout. You may need a break to break down and focus on what you have to do and be quiet in order to be able to handle all the stimuli that's coming in your way. So stress, pain, hospitalization, having different testing done and surgeries and treatment is a lot of stimulation coming in for somebody to process. Medications can impact your ability to take on and perceive the way different stimuli comes through. Narcotics and sedatives decrease awareness of sensory stimuli, and antipsychotics can influence how sensory stimuli are perceived and processed as well. So why are senses so important? Now, if you have sensory impairment, that can put you at risk for different environmental dangers. So the sense of touch protects us, keeps us away from hot surfaces. It also tells us we know when we have infections. If you have a cut, then it has the signs and symptoms of infection, and inflammation might come up, and then you can take care of it. The sense of smell protects us from food poisoning and gas leaks. The sense of sight protects us by allowing us to walk safely. It prevents falls, and it also can help prevent accidental poisonings. I don't know if you guys remember the 80s movie. I know I keep talking about 80s movies, sorry. 9 to 5 with Dolly Parton, and she accidentally poisons the boss with a box of rat poison that looked like the sweetener for the coffee. And so things like that do look similar and are maybe in our kitchen, like cleaning products and things. Our sense of sight protects us from accidentally eating the wrong thing. Hearing protects us by hearing people shout for us. It protects us in road accidents and fire accidents, like fire alarms going off. And then taste protects us from eating toxic things, and protects us from food poisoning. The other thing is that aside from being vital to our survival and for keeping us away from harm, our senses bring us a lot of joy. I can't speak for you guys, but I find a lot of joy in, even just the smell of my children. And sometimes, maybe not all the times, maybe sometimes they don't smell good. But also, smelling flowers and seeing the sunshine and feeling a warm breeze and feeling the warmth of the sun on my shoulders, feeling sand between my toes. And taste, obviously, is a big deal for joy, right? So it really impacts our quality of life. And so it doesn't just protect us, but it also helps us to just love life. So sensory perception in children is going to be different than what you see in adults. Vision in newborns, when children are born, they can only see 8 to 15 inches in front of them, which is interesting to me because it is about the same distance as when a mother is feeding her child. It's about how far that mother's face is from the baby. So the baby can see their mother's face when they're feeding, but not much past that. They are nearsighted as newborns, and sometimes their eyes can wander and cross. They do not get full color vision until about 7 months old. And then they will begin at that time also to begin to improve with their vision distance and being able to track objects. It is sometimes can be an issue if their eyes are still crossed most of the time after 6 months is when they may think that's an issue, because before that it's not an issue. It's developmentally normal. Hearing is intact at birth, and by 1 month babies can recognize familiar sounds. If they are not turning to sounds by 4 months or not responding to loud noises, then that can be a sign that their hearing is impaired. And smell and taste are intact at birth, so I think that's interesting as well. So reflexes in newborns, they have some reflexes that we don't have anymore as adults. One of those is the Moro reflex, which is also called the startle reflex. It's a response to a loud noise or a sudden movement. It's the sensation of falling that babies have at birth. It usually goes away by about 6 weeks old. If you've been around newborns very much, you've seen that. It's kind of cute, but probably not for them. The root reflex is whenever you gently stroke the newborn's cheek, the baby will turn towards that touch and open their mouth. And it's just it's the way babies kind of learn to eat like that. And that's how they learn to find food. So that lasts until about 3 or 4 months. The Babinski reflex is going to be where you gently stroke the sole of the foot from the heel to the toe. And what happens is that the foot turns in and their toes flare. I'm just going to turn on my little dryer. So you just go up the heel with your thumb. You can do the back of your thumb, and their feet will flare. And that usually lasts until anywhere from 6 months to 2 years. It is not present in adults, and if you see it in adults, it's bad. It's a sign of severe neurologic damage. And then lastly, they have the grasp reflex. And so anything that touches the inside of a baby's hand into their palm, they'll make a fist and grab that object. And that appears at birth and will last until 3 to 6 months. Okay, so assessments related to the senses. Remember, we want to know what the client's history is and what is baseline for your client. Do they wear glasses normally? Do they use assistive devices to hear? Do they take medications that could cause impairment? Do they work around any of those things like we talked about with loud noises that could have led to some hearing loss? Do they have any history of head trauma? So these are some things we may want to know ahead of time. We want to check for PERLA. If you don't know what that is by now, I suggest you do some major reviewing in Unit 1. We can also test visual acuity with the Snellen chart, which is 20 feet away and one eye at a time, trying to read the smallest line. We could also check the head for symmetry, any kind of distortions or things that are abnormal. We can do something easy like a whisper test to check hearing, just to see if our clients can hear us on both sides. If we don't have the full audiometer to actually assess for hearing loss, but you'll actually learn how to use towards the end of this semester in preparation for pediatrics in the spring for your pediatric rotations. You can use an otoscope to examine the ear canal and the tympanic membrane. Cerumen or ear wax is normal. A little bit is normal, but a buildup or a plug may have to be cleaned out. It's usually done by lavage if you cannot, if it is clogged, so that sound is able to travel. As far as the way the ear canal should look, the ear canal should be pink, but the tympanic membrane or the eardrum should be a shiny gray color. If it is red, it is typically an ear infection. So we'll also check the nose for patency and look for a deviated septum. And that's image here, which if you look up into somebody's nose, and you can see if that septum is straight or deviated. We'll also palpate the sinuses for pain or edema. Lips, when you look at the mouth, lips should be pink and moist and smooth, and the mucous membrane should be pink and free from swelling or lesions. We'll also assess the teeth and the tongue. A white coating on the tongue can be from smoking. It could be from poor hygiene or irritation. If it's fissured, that could be from dehydration. And it can sometimes be, if it's black or hair, it can be from antibiotic use, that thrush. So let's look at some of the sensory and perception changes we see in the older adult. So the prefix of presby means old. So presbyopia means old eyes. So that is the, there's a decrease in elasticity of the lens that causes a decreased ability for the eye to change shape, to focus on near objects. So in that case, we need to make sure that clients have their glasses available, provide adequate lighting and clear paths of clutter. We also want to provide large print if it is available. The next one will be presbycusis, which is a decrease in hearing high frequency sounds. It progresses bilaterally with a gradual onset. So that's how we know it's age related and not some sort of an injury or an infection or a disease process. Due to the loss of hair cells and fibrous changes in the blood vessels that supply that ear and conduct the impulses. So we want to encourage clients to use hearing aids if applicable. We can try to speak in a lower tone. I personally, because the tone of my voice is more difficult for people who are hearing impaired, older adults who are hearing impaired to hear. So I have before gotten my male counterparts and coworkers to go in and communicate with for me. And people who are hard of hearing were able to hear them fine, where I could be screaming and they just couldn't hear anything else say. Another thing that helps is if they can see your mouth. Obviously, this is going to be a problem for us this semester. And for anybody who's on isolation on the regular day, not to be able to see our mouth. So we need to make sure we're speaking slowly and clearly and regularly checking to make sure they understand what we're talking to them about. So taste, smell can also be impacted with age, and it can, a decreased smell can also impact the way you taste foods. So tobacco use and some disease processes and also some medications can affect your sense of taste and smell. We know that's one of the things going on with COVID right now, is that loss of taste and smell is one of the symptoms that people are seeing. So one thing to be careful though with older adults as far as that decrease in taste and smell, if their taste is decreased and they have, stuff doesn't taste as sweet to them or stuff doesn't taste as flavorful to them, then they may be adding extra sugar or extra salt to their food. And because of different disease processes that also may be going on in the older adult, that could be bad for them to be adding extra sugar or salt to their food. So that's something to be monitored. And then the sense of touch, the peripheral nerve function can decrease with age, and it can also cause a decreased reaction time. So we definitely want to protect their skin from extreme temperatures and assess for skin breakdown and skin tears regularly, because they may not feel them when they pop up. We also, for that matter, we want them to ambulate with assisted devices as necessary to prevent falls and injury for that reason as well. So the nurse's role when caring for the visually impaired clients. It's going to be important to include family as patients tend to slowly adapt to the impairment that that is happening over time, and they might not notice the change. So family may be able to report changes that the client hasn't recognized yet. We definitely want to know the patient's history to be able to determine the cause and issue in perception and sensory perception. You'll want to check with the healthcare provider to find out if the patient's visual problem is going to be something temporary or permanent or continue to progress, because that'll be important to your plan of care with your client. So we want to teach clients some self-care behaviors for taking care of their vision and to prevent vision loss. So a couple of those things is just not to be rubbing your eyes. Exercise can help keep a healthy blood flow to your eyes. Plentiful sleep will keep your eyes lubricated and helps remove any irritants. You want to avoid eye strain from mom telling you not to read in the dark and that you needed a better light is a real thing. So make sure you have adequate lighting for reading or viewing television. Avoid damage from ultraviolet rays. The UV rays from the sun can damage your eyes just like they damage your skin. And then protect your eyes from any foreign bodies. If you do wear eyeglasses, keep them clean and protected and adjusted appropriately. And if you're caring for a client with reduced vision in the hospital, here's some things to think about. Make sure you acknowledge your presence when you come into the room and identify yourself by name. Speak in a normal tone of voice, and remember that a person who's blind or visually impaired is not going to be able to pick up on your nonverbal cues. So you can talk with your hands as much as you want, but they are not going to be able to pick up on any of your nonverbal facial expressions, hand movements that you're using. Make sure you let them know that you are touching the person before you do so, and that the call bell is in easy reach and place where they can get to it. Make sure you orient them to the sounds in the environment and to the environment in general. You need to make sure that if people are in the hospital, that, as I said, call bells close and then pathways are clear. If somebody is at home, you cannot rearrange their furniture because they get used to where everything is, and without it, if it gets moved, it can cause injury from falls or walking into things. My sweet little grandmother who would fall off the washing machine, she also, she had some vision impairment, which she refused to acknowledge. And so at her house, she was pretty good because she knew where everything was. She could go around and do the things she was supposed to do. A couple things we had to be careful about was the dishes, because she would wash the dishes, but she couldn't see the dishes that she was washing, and they were dirt. They were never clean. They were always dirty, and then she just put everything away. Sometimes with it still had food on it that she put in the cabinets. So we had to regularly like take everything out and rewash all her stuff for her to keep all her dishes clean. Same with things that went old in the refrigerator. She couldn't see if something had mold or anything on it. We had to keep a close eye on what was in the refrigerator. And if somebody left something in the way, she would trip over it, get skin tears. And but she refused. She didn't have a vision problem though, according to her. She would tell you that she could see perfectly fine. So just be aware of what's going on with your patients. Secondly, let's talk about caring for a patient that is hearing impaired. Some hearing impairment could be temporary if there's been some sort of a wax buildup or a foreign object obstruction or an infection. However, with older adults, a lot of times it's going to be progressive hearing loss that's not going to be returning to normal without assistive devices. So a couple of things that we can teach our clients to prevent hearing problems is to watch weight and blood sugar and blood pressure to keep those tiny arteries that fuel your ears healthy. Avoid excessive noise. I'm pretty sure we're going to have a whole generation of people who can't hear with all the headphones and earbuds that everybody has in. Don't clean ears excessively because you can push the wax into them. Treat ear infections quickly and early to prevent any damage. And then know the signs of hearing loss. If you have to frequently ask others to repeat what they said, or you can't hear a sound in a distance, you need to be, if you need to be able to see the person that's talking to you, or you find yourself leaning forward or turning towards the speaker, these are all signs that you may have some hearing deficit. And so if you're communicating with a client that has a hearing deficit or an impairment, just continue to follow these guidelines and think about how to treat your patients. Orient the person to your presence before initiating a conversation. So maybe don't yell from the door, "Hey, Mrs. Jones," but actually move so that they can see you, or gently touch them so that they know you're there. Decrease background noises whenever you're going to talk, so that there's just the one sound in the room. Make sure that if it is applicable that your clients are wearing their hearing aids, and do protect your patients' hearing aids. People use their hearing aids in the hospital all the time, and they are very expensive. Position yourself so that they can, if this is going to be a problem with COVID, but if you weren't wearing a mask, you would position yourself so that your client can see your face and look and see your mouth moving. If that's the case, if they are able to see your mouth, also don't cover your mouth or turn away, and don't chew gum, because that can be a distraction when they're trying to read your lips. You can also use whiteboards and communication boards, writing things back and forth. Some hospitals have the technology to be able to use devices, if there's different communication devices or iPads that can be used. That can be helpful as well. You'll get some more information on caring for clients with cognitive impairment later this semester, but I'm going to hit on caring for a confused client and the communication that's necessary. As far as the environment goes, always think about safety and protecting these clients from falls and harm. We want to use bed alarms and keep the day as structured as possible. In communication with confused clients, we want to have face-to-face contact and use a calm voice with simple explanations as much as we can. And then as far as orientation goes, we are going to be constantly reorienting our clients to their surroundings. Mrs. Jones, you're here in the hospital, you had a fall, we're helping you to heal, this is what we're doing, this is the day of the week, your daughter will be up here later, but constantly reorienting our clients to who and what and where they are and what's going on. One time my mom fell and hit her head, and I asked her later, was she confused? And her response was, well, it's kind of weird but at the time, I didn't think I was confused. I thought everybody else was confused. I thought everybody else was wrong about what was going on. But in hindsight, I had no idea what was going on. So just keep that in mind. We may have to do some convincing to reorient your clients. So when communicating with our confused clients, some nursing interventions we may want to implement is, as I said, making sure you have face-to-face contact as much as possible. Use touch appropriately. If therapeutic touch is calming for your client, then a hand on the shoulder can help. Speak calmly and simply and directly. and allow time for your client to think about what you said before responding. Use conversation and watches, clocks. Use the calendar and your communication board in your room as much as possible to help your client stay oriented to time, place, and person. And then make sure you clearly communicate any expectations for your client and safety regulations, continuing to remind and re-implement things as needed to keep your patient safe. So let's talk about care of an unconscious client. So if you're caring for somebody who is unconscious, there's a few things you want to do as far as the environmental noise. You want to decrease it. You don't want to just assume that they are not taking in all of the stimuli around them. So we want to keep environmental noise low. And we want to treat that client as if that they are conscious. We want to assume that they can hear us. We will speak in a normal tone and talk to them before touching them. So it is believed that when people are unconscious, they can still hear us. So that is how we treat our clients. So we want to be careful of what we say in their presence. We don't want to do anything unprofessional and assume that they just can't hear us. So please be aware of that and treat your client professionally. Assume they can hear you and talk with them in a normal tone. As I said, speak with them or let them know before you touch them. Therapeutic touch is going to be very important and can be very calming for an unconscious client. So make sure you let them know you're going to touch them before you do. So let's talk about disturbances in sensory perception. Remember, that perception has to do with your ability to make that stimuli meaningful. So sensory deprivation is going to happen when there is a decreased amount of input or flat, meaningless input. There's not enough stimuli coming in for the brain to maintain a normal level of activity. Things that can happen with sensory deprivation, if there's not enough coming in, then the brain can hallucinate, and hallucinations can begin because the brain is trying to maintain a normal level of activity. People who are at risk for sensory deprivation are going to be people in social isolation. So that's going to include prisoners, patients who are on isolation or bed rest and are not allowed family members present. So that's basically a lot of our hospital population right now, right? With COVID and the visitation limitations, there is a lot of our population who are going to be at risk for sensory deprivation. So another thing to think about is people who have impaired vision or hearing or some sort of damage to the nervous systems that makes it hard for them to process messages. Because remember, it doesn't mean that there's necessarily not anything coming in. It could be that it's not meaningful or that they're not accepting it. The people who can't hear or see may have that a problem with not having enough coming in. But this can also be true for language barrier patients. If people do not speak any English and they're in a hospital and all they hear is people speaking English all the time, that is not meaningful input for them. It's meaningless. It's going to be just flat input that's not causing any kind of arousal for the brain. So keep that in mind as well. Sensory overload is going to be when there's too much input, excessive input, and it will make the person feel like they don't have any control because the brain is unable to respond to or ignore the stimuli. It's just too much all coming in. People who are at risk for overload are going to be people who are in pain, people in ICU, and also in the regular floor. If that monitoring equipment, monitors beeping, flickering lights, sounds of machinery is going to cause put them at risk for overload. So our current technology is putting us all at risk of sensory overload, right? Because there's just so much information coming in at us all the time. When we talk about sensory deficits, the difference in sensory deficit and deprivation is that sensory deficit is going to be the impairment or absence of functioning of your senses, where sensory deprivation is going to be that there's not enough input coming in. Now, are people with sensory deficits at risk for deprivation? Yes, they are. So as we've just talked about people at risk for sensory disturbances in their sensory perception and people who are unconscious, I'm going to just talk to you quickly about, we're going to do a little case study real quick and think about what could be affecting somebody who's unconscious. So you are a CCU nurse caring for a 37-year-old teacher who recently suffered a severe trauma. She's in a medically induced coma to facilitate healing. So how could the treatment your client is receiving affect her sensory perception? I want you to think about that for a minute. You can pause this if you want to. But the CCU environment is got a lot of sounds and activities that can add to problems with alterations. So what type of alterations do you think you might see? So it may be sensory overload because of all the sounds and lights and everything going on around them. They could also be at risk for sensory deprivation if there's not meaningful stimuli coming in. If they're not getting physical touch and the attention and people actually talking to them and getting that meaningful input. So how could you focus your nursing care to reduce the sensory alterations? You can decrease the stimuli, make sure that there's not any more beeping that needs to go on inside the room. You can introduce familiar people and things that are positive for stimulation. Have people at the bedside who are familiar if that's possible. You can talk kindly and positively to your patient and provide some therapeutic touch. So I'm just going to show you a video that is a lady who went through a trauma and her experience as in that type of a situation.
I woke up in intensive care. My eyes were swollen shut, I couldn't see. My jaw was wired closed, and there was a hole in my throat, so I couldn't eat, I couldn't speak, I couldn't drink. And there was a machine forcing air through the hole in my throat, so I couldn't even breathe for myself. But I could hear everything. And I searched through all the noises of the busy intensive care unit for any sign about what was happening or likely to happen to me. And then a machine would beep loudly. I couldn't see, and I didn't know what it was. And I thought that maybe I was going to die. But somebody would come and they would reset the alarm and move away silently. The doctors would come around the bed and they would discuss my case in great detail with each other in a language that I didn't understand. And then they too would just quietly go away. And at night, nurses would come and they would attend to the IV lines that fed and hydrated and medicated me, and they would take notes, I suppose, and read things. And they attended to my physical needs with skill deficiency, but they never saw, they never acknowledged my emotional wound, except for one special nurse. Every time he came in to look after me, he would lean close to my face and put his hand on my shoulder. And I could see through the slits in my eyes the outline of him, and he would call me by name. And then he would tell me what he was going to be doing that day. And then he did something that not one other person did for the 3 weeks that I was on life support. He talked to me like a human being. He would talk about everyday things as he went about cleaning my wounds, cleaning my body, washing me, changing my clothes, checking my IV lines. He would talk about things like what kind of a day it was outside, or who would come to visit me while I was asleep. He talked about common everyday things, and it didn't take him a moment longer than it might have taken otherwise. People are so afraid that if you make a human connection with a patient, that it's going to take too much time. It took him no extra time. And yet, 20 years later, it was 20 years ago that I had a multi-trauma accident that nearly killed me and kept me in hospitals for 17 years. But I remember him, and every time I speak, I tell the story of this nurse, this wonderful man, and how much his touch that didn't hurt, that wasn't efficient, how much that meant to me, how much telling me what the weather was like outside, or telling me a little anecdote about something that was on the news, anything like that reminded me that I was more than a broken body. And I will never forget him. And it's 20 years. And I still feel the gratitude of that more deeply than I can express to you.
Okay, so I wanted to share that with you because that's what's real. That's what's real for your clients who are unconscious, who are afraid, who don't know what all the loud noises are, their senses are overloaded or their sense deprived, and they're having a hard time putting the pieces of all that is happening around them together. Their body can't put those pieces together. So be that nurse. Be that nurse that comforts and reorients and treats every patient with dignity and kindness. There are some charts in your book that go over people who are at risk for different alterations in sensory perception and some nursing interventions and things with that. So I would encourage you to look over those as well. If you have any questions, concerns, or comments, please reach out to me via email or the discussion forum in the Unit 2 folder.